Thank you very much, Professor Carol Benn, for giving me this opportunity to speak about radiotherapy during lumpectomy for breast cancer and how the evidence, very robust long-term evidence, shows how this is better for patients and better for healthcare systems. Now, only recently, completely unbeknown to us, the UK National Institute of Health Research put up this news or post that 5 amazing health research breakthroughs, not cancer, just health research breakthroughs in the last 12 months. And they included among these 5 items, alongside the Oxford COVID vaccine and 2 COVID treatments, TARGIT-IORT for breast cancer. So to be included in that list was quite nice, and it just felt very good. And why might they have done this? So this is one single slide that can, if that's the message to take away from here, is that TARGIT-IORT using intrabeam reduces deaths and improves quality of life in breast cancer patients. And there is randomized evidence to show behind saying this statement. And because of this, over 50,000 patients in 260 centers from 38 countries have been treated with TARGIT-IORT, and each of these circles denotes a center where patients have been offered intraoperative radiotherapy for breast cancer. I'm going to talk about the latest evidence, and this is the writing committee, Professor Michael Baum, Professor Jeffrey Tobias, and Professor Max Balsara along with me, and these are the list of authors of all the recent papers that have been published since 2020. What we have been doing over the last 20-25 years is challenging the dogma of radical radiotherapy, which was established between 1960 and 1990. During this period, in the last 125 years, we have moved in terms of surgery. We have moved from radical surgery, as you can see from the left-hand side of this figure, to more targeted surgery where the patient doesn't even recognize that there is some operation done. You can hardly see this scar here. But what we have done since 1995 is moved away from radical radiotherapy towards more targeted radiotherapy, and this is a story I'm going to try and tell you in the next 20 to 25 minutes. So I will try and show you how TARGIT-IORT during lumpectomy should be a standard option to patients with breast cancer because of many reasons, and this is a list of about 15 reasons. How it is convenient for the patient, it's easier on the patient, it is better quality of life and satisfaction and cosmesis, it's less expensive to the community, it's simple to deliver, and it is devised by clinicians and tested by clinicians, trialists, and patients. It is quicker, it's all finished during the lumpectomy procedure. It is individualized. We can add whole breast radiotherapy if required. It is accurate and timely and has been time tested since 1998. There is long-term randomized evidence. It reduces deaths from other causes and improves overall survival in patients with grade 1 and 2 cancers. And when whole breast radiotherapy is not an option, TARGIT-IORT can avoid mastectomy. So these are the various points I'm going to come to you. And I would like to first thank and acknowledge the great effort put up in these institutions around the world, the patients, the clinicians, and the trial teams. This is the International Steering Committee on top, and this is the NIHR HTA appointed trial steering committee. These are the authors in the recent papers, and these are my potential conflicts of interest, the grant funding from NIHR and honorary and travel reimbursement from Carl Zeiss. So, as many of you will already know, main treatment for breast cancer in terms of local treatment is lumpectomy, where radiotherapy is normally required, and mastectomy, where radiotherapy is not usually required. So after a cancer operation, if this is a lumpectomy, patient has to go every day for 3 to 6 weeks to the radiotherapy center. And not only can this be onerous, but it can be sometimes make the patient choose a mastectomy. And I saw this when I was in India as a chief resident, that after telling the patients that you have breast cancer, next question I had to ask them was, can you come to the hospital every day for 6 weeks of radiotherapy? If the answer was yes, we could preserve the breast. If the answer was no, we had to do a mastectomy. And this is not limited to India. It happens in UCSF in USA, in Australia, in Denmark, And even in the UK, you can see these red dots which represent 13-mile radius around a radiotherapy center. So all the green areas, people have to travel more than 2 hours every day for their radiotherapy. So this is a worldwide problem. In addition, harmful effects of scattered irradiation of the whole breast is well known. It gives to irradiation of heart and coronary vessels, which increases the risk of heart attacks, and radiation of organs such as the lung and esophagus can lead to development of fatal cancers, which is much more fatal than breast cancer. And this risk is much more in smokers. So patients should not really need to choose and forced to choose between mastectomy or no radiotherapy just because they cannot take radiotherapy. So this was the human rationale and clinical rationale. But there was a biological and pathological rationale as well. In the lab, I found, when I did a whole organ analysis of mastectomy specimens, that breast has many other microscopic cancers, like those green dots. But when recurrences occur, like the red ones, they occur only around the primary tumor and very rarely in other parts of the breast, just like they happen in the other breast. We don't treat the other breast, so why should we give radiotherapy to the whole breast? So the translation of this laboratory finding was that it would be sensible to target radiotherapy just to the tumor bed. And it was this academic insight that we published in the mid-1990s that led to the idea of giving targeted radiotherapy. So this academic insight of radiating only the tumor bed led to a collaboration with the industry to develop a device to give this radiotherapy and the clinical trial to test whether this is enough for controlling breast cancer. So the target technique was developed in UCL and Middlesex Hospital between 1996 and 1998. It's a very simple technique of involves after lumpectomy, this applicator is inserted in the tumor bed, and the size of the applicator can be chosen according to the size of the tumor bed, so it can be individualized to each patient's tumor bed and tumor size and the breast size. Radiotherapy can be delivered immediately after lumpectomy. Focused radiation to the tumor bed. It targets tissues at the highest risk of relapse and avoids normal structures, going through the principle of precision and immediacy. It is ideal for patients during the pandemic. You can see me in COVID gear during the treatment, and that's how it looks. This photograph on the right is taken in South Korea, where they're doing this, and this covers and protects the staff in the operation theater during the radiation. These are lead shields, but nothing else is needed to do a special theater. So it is COVID safe. So this technique, first case was done on 2nd of July 1998, and you can see here Professor Michael Baum and Professor Jeffrey Tobias, who along with whom we developed this technique. And you can see here a photograph and a video of how it is done in a careful manner. So this is for the surgeons. The green line here shows the tumor bed, and the red is the purse string suture that is taken just under the skin, so that the dermis is kept 8 to 10 millimeters away so that it doesn't get radiation. At the same time, the whole of the green area should wrap closely around the applicator surface. And you can see how in this video, this purse string is taken at the right place, just under the skin, but not in the dermis and not in the skin. And when this is tied, the tumor bed approximates the applicator surface, giving radiation to the correct tissues. And this happens in front of the eyes of the surgeon, is done accurately and timely. So there is no geographical miss and no temporal miss. Okay. So we published this technique, and we published the first 25 patients' results. And then we said we should start a randomized clinical trial, asking the question, can risk-adapted single-dose target IORT during lumpectomy for breast cancer effectively replace the usual 3 to 6 weeks of post-operative radiotherapy? The recruitment of this TARGIT-A randomized trial started in March 2000 and finished in July 2012. And TARGIT stands for Targeted Intraoperative Radiotherapy. This is the gold standard of testing any new treatment, comparing in a randomized manner whether radiotherapy given during the operation versus given afterwards is as good. 2,296 patients participated. They had They had to have age more than 45 or equal to 45, tumor size preferably less than 3.5 centimeters. We did not require MRI. The trial started in year 2000, and this was the random allocation. So now we have really long-term data. We published the first result in 2010, 10 years after starting the trial, in the Lancet, and Lancet put our conclusions on the front page masthead, saying that TARGIT-IORT should be considered as an alternative to whole breast radiotherapy. We published the first results of survival and 5-year results in the Lancet again, confirming our initial conclusions. And since then, we have been following up the patients for a longer period. And while waiting for these results, many of the obvious benefits of TARGIT-IORT were confirmed. You can see here that the cosmetic outcome is superior with TARGIT-IORT because we give radiation to only a small area. An objective assessment confirmed this. We assessed whether quality of life is superior, and yes, it was. This was assessed in Germany and in Australia, where radiation-related quality of life as well as cosmetic and breast-related quality of life was superior with TARGIT-IORT compared with whole breast radiotherapy. This study from Denmark showed that patients have less pain and less breast and arm symptoms when they receive TARGIT-IORT rather than whole breast post-operative radiotherapy. When we asked patients and doctors whether they would prefer TARGIT-IORT even if there was increased local recurrence, and now we know there is no increase in local control problems. So in US and in Australia, patients and doctors prefer TARGIT-IORT. And this is the most recent study from the west coast of America, where when patients were consistently offered, for patients over 65, whether they were offered TARGIT-IORT, all whole breast radiotherapy, or omission of radiotherapy altogether, or a mastectomy, 3/4 of patients chose to have TARGIT-IORT. It is also cost saving. In the US, using Target as a single dose in the operation theater would save about $1.4 billion over 5 years. In the UK, it would save less money because it is less expensive to give whole breast radiotherapy, but still it would save about £9 million per year in the UK. And this does not involve the environmental, patient, or societal costs. And these have been looked at in this study published in the BMJ Open, where we found that there is a big difference in environmental cost. There is about 700 traveling that is avoided by patients who take TARGIT-IORT. Target improves tumor microenvironment. This is another very interesting biological study. In this, we found that after surgery, there is no proliferation. The wound fluid that collects in the surgical bed actually stimulates cancer cells. It makes them grow faster, move faster, and invade more. This study was done in Italy with Dr. Masaruth and Dr. Baldassare. But what was interesting is that if has had TARGIT-IORT during the lumpectomy procedure, this stimulatory effect of wound fluid on cancer cells is abrogated. You can see here how it is significantly reduced, and in the top diagram you can see cells moving very fast, whereas in the bottom diagram they are not moving fast. The bottom diagram are cancer cells bathing in wound fluid taken after patient has had TARGIT-IORT during the lumpectomy. So these are all the benefits that you can see, and these are the publications that show how it has many benefits for patients: better cosmetic outcome, better quality of life, less pain, patients prefer it, it is cost saving and reduces patients' travels. But what about the long-term outcomes? And these are what has been recently published. We know that breast cancer has long natural history, so long-term outcomes are important. And for long-term outcomes, we set the follow-up for completeness of follow-up, we set this bar very high. We said that follow-up was considered complete only if 95% patients had at least 5-year complete follow-up and 90% patients had at least 10-year follow-up or had been seen in the previous year. Patients from all over the world participated in getting us this completeness of follow-up, and this is one of our meetings. The Surgical Interventional Trials Unit team at UCL were instrumental in making this happen, and consequently, Target-A had the largest amount of follow-up data amongst partial breast irradiation trials for invasive breast cancer. You can see this skyscraper graph in which you can see Target-A trial has more data than any other trial for partial breast irradiation. In the trial, the randomized arms were well matched for all the patient and tumor characteristics, and of importance here is that for age and BMI, which are risk factors for other cancer deaths and cardiovascular deaths, there was absolutely no difference between the two randomized arms. So these are other patient tumor characteristics, which was no difference. So these were the advantages. Yes, all good and huge advantage during pandemic. But what is the patient thinking? She's thinking, what is my chance of living without the cancer coming back? And so here are the results. They are published in the British Medical Journal and British Journal of Cancer. You can scan the QR codes on top with your phone. That will take you directly to the website of these journals to download the paper PDF. So, first question, what is the chance of remaining free of cancer in the breast? This is the most important question for local treatment of breast cancer, and this signifies the local control. Between the two arms of the trial, there was absolutely no difference in local control, despite the target giving just a single dose during the operation theater in 80% of cases. So you can see no difference in local recurrence-free survival, no difference in invasive local recurrence-free survival. What is the chance of preserving my breast? Here, no difference in the two arms of the trial. Breast preservation was equally good as giving whole breast radiotherapy. What is the chance of remaining free of cancer elsewhere in the body? Absolutely no difference as well. So local control as per the treatment received. Some patients received target, some 20% received target plus EBRT, and the randomized arm was EBRT. No difference at all in terms of local control. And we also found that local relapse after whole breast radiotherapy has poor prognosis, and this has been known for a long time. But with TARGIT-IORT, the local control was, even if there was a rare local recurrence, the outcome was as good. You can see here the top line, which is long-term hazard of breast cancer death if patients had a local recurrence after EBRT. And what you can see here is that it is much higher relapse death rate if patients have local recurrence after whole breast radiotherapy. But if patients have local recurrence after TARGIT-IORT, there is no long-term hazard of breast cancer death. It is the same as if and as good as without a relapse. This is really very good news. We also did subgroup analysis in terms of for local control. We found that there is comparable local control in every tumor subgroup as long as patients are eligible for the Target-A trial. This is the most important thing that patients are worried about, is survival from breast cancer. There was absolutely no difference in breast cancer mortality between these two arms, despite one group having such a short treatment finished during the operation. But this is the great bonus. What is the chance of dying from other causes? There was a significant reduction in deaths from other causes. So it was almost halved. With Target, there were fewer deaths from non-breast cancer causes such as cardiovascular causes, lung problems, and other cancers. So this is a significant benefit for Target-IORT. This is not a surprise because we know that avoiding whole breast radiotherapy will avoid the cardiac perfusion defects that occur within 6 months and other cancers which are more fatal. So this is not a surprise. And in smokers, this risk is much higher. At the end of 30 years of follow-up, a 50-year-old patient will have a 23% chance of dying from lung cancer or heart attacks if they were smokers. This is a 6% increase. And there is no way radiotherapy can improve breast cancer survival by 6%. So I believe it's unethical not to offer Target-IORT to eligible patients who are smokers. So they must be offered Target-IORT. Now the most important outcome is overall survival. When we did subgroup analysis, we found that for grade 1 and 2 cancers, there was an improvement in overall survival. And grade 1 and 2 cancers formed most of the patients in Target-A trial. It was unchanged in other patients. So you can see here the survival graph. So grade 1 2 cancers, there's an improvement, so reduction in mortality from 15% to 10.5% in a large number of nearly 1,800 patients. And for grade 3 cancers, there was no difference in mortality, so they got all the other benefits without hampering their mortality. And this difference in reduction in mortality is similar to other drugs such as trastuzumab, which is very expensive, and when given, the benefit is very similar. And so this benefit of Target is very similar to the benefit of trastuzumab, called Herceptin. It costs 50,000 pounds and hurts the heart, where Target is cost saving and protects the heart. So this is the perspective of this benefit. So the new insights of the Target-A trial are that it can be given to patients who are eligible for Target-A, it's 45 ages and older, and less than 3.5 centimeters in size, invasive ductal carcinomas, suitable for breast conserving surgery. So this is the evidence-based guideline for clinical implementation. It allows improved overall survival in grade 1 and 2 cancers, and no detriment if grade 3. Who needs whole breast radiotherapy? You can scan this barcode and go to this website to help you make that decision. Unlike EBRT, patients who received Target-IORT have very good prognosis even if they have local recurrence, and there seems to be a beneficial abscopal effect that seems to protect against cardiovascular, lung, and other cancer deaths. So the first results were published in 2010. Long-term results have now been published that show that the breast cancer control is comparable with EBRT. There is reduced non-breast cancer mortality, effective in all ductal subtypes. There is improved overall survival if grade 1 and 2, and it reduces non-breast cancer mortality even when additional EBRT is given. We must remember that Target-A had substantial high-risk population, typical of a cohort seen in our breast clinics. So a large proportion of patients were young. There was a significant proportion of grade 3 patients, patients with positive nodes, or ER/PR negative patients. This is very different from other trials of no radiotherapy and most of the other partial breast radiation trials. So this can be applicable to standard patients in our clinics. Is no radiotherapy a good idea? I don't believe that, and that's the evidence to show that it's not a good idea. Even though in the PRIME 2 trial, patients were highly selected, only older patients, grade 1 and 2, ER positive and node negative. Yet, after 10 years, 10% patients had local recurrence compared with 0.9%. And I think that this might have led to increased breast cancer deaths that has wiped out any benefit of avoiding radiotherapy in this trial. So that is the problem. And patients don't want to avoid radiotherapy, as we have seen from this study. Is 5-day fast-forward regimen a good idea? This is a backward step, not a forward step. It radiates the whole breast. There is scattered irradiation to vital organs. There is no reduction in mortality. And because you give such a high dose in very few fractions, a quarter of patients report having a hardened and firm breast. And breast induration is 19 times higher by physician assessment. And there is no long-term data. So this is so much worse than Target-IORT, which is finished during the operation. There is fewer deaths and so much more convenient for the patient with improved quality of life. So fast forward is not really going forward. Other methods of giving partial breast using brachytherapy, it looks really quite nasty that way, and there is no reduction in mortality. External beam partial breast radiation has higher toxicity with no reduction in mortality, and you've seen all the benefits of Target. These data are published in this paper in British Journal of Cancer last year. You can scan this QR code to go to the page, and it shows a table of all the new methods of radiation, modern radiotherapy techniques, and compares and contrasts them as one might want to have for patients to choose. We have seen how it is better for patients than other PBI approaches. This is the Red Journal publication. This is in Nature Reviews, Clinical Oncology, how there is now powerful evidence to change practice. And many prospective studies have done in all parts of the world. And you can see here, this is a study from Montpellier in France, where they have replicated what we have found, a low 5-year local recurrence rate. This is a study from China, where they found similar local recurrence rate as whole breast radiotherapy. This study is in Russia, where they have now treated over 1,200 patients. This is again from France, from 3 centers, low recurrence rate. This is a European study from Germany, France, Denmark, and Switzerland, where they had very low recurrence rate in elderly patients. And this study comes from South Africa, where first 2 years in operation, it was found that there is very good patient acceptance and a very good method of implementation. And the Professor Carol Benn and Yastira Ramdas are participating in Target-B trial as well. It can be done at the same time as oncoplastic surgery, enabling high precision and immediacy. Target data was first presented in 2012 in San Antonio to a very large audience. Since then, we have been having meetings every year of target users, and this group is growing every year. As you can see, we've been having meetings in Germany, in USA, in Far East, in Bangkok. These are meetings more recently in US, in Germany, 2019, and this was the last meeting we had in New Orleans just before the pandemic. As I've said before, data from each of these centers has been given to me in terms of number of patients treated, and we know by 2020 at least 45,000 patients were treated. We have seen that there has been a lot of publicity about Target-IORT in many parts of the world, in many newspapers, how it is a revolution for breast cancer treatments, and it was approved by NICE in the UK in 2014 and given final approval in 2018. It was approved in Australia for government funding. Our new paper made a headline in the Times above the fold on the front page. And during the COVID pandemic, most centers have reported they've been treating many more patients with Target-IORT. So all these are benefits. Are there any downsides? Now, the chief editor of the top radiotherapy journal has said that depending on your perspective, it could be a very serious threat or a quantum leap forward. But if patients are treated and the payment is made by value, then it should not be a threat at all to anybody. It's a win-win situation. Until now, I've been speaking about Target-IORT as the only radiation treatment and results of Target-A trial, which have been published. Target-Boost trial is currently recruited and is open to new centers, and it appears that it may improve local control as well as survival. This is a trial of high-risk patients who are not suitable for Target-A, younger than 45 or at high risk. We are aiming to recruit 1796 patients. We have already recruited 1,650 patients in 38 centers around the world, including UK, Europe, US, South Korea, China, the Middle East, South Africa. We recruited more than 400 patients during the pandemic. And we hope to get those results out in about 3 or 4 years' time. But meanwhile, the long-term outcomes of the Target-A trial has shown that it is as good as whole breast radiotherapy in terms of local control, but improves overall survival in grade 1 and 2 cancers and no detriment in grade 3. It is better for patients, has several advantages. If you want to have a single slide to see the results of Target-A, you can take a screenshot of this slide, which tells you all the results in a single place. So I'll let you take that screenshot if you want. And I'll leave you with this patient.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early-stage breast cancer. I had it for 2 months only before I was cured. I had Target-IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had Target. I am so happy I was able to have this treatment.
Thank you very much for this opportunity. I'm happy to take questions. Thank you.